refuse and got your cup of coffee and had the renewal. So welcome back to the next session. Before I start, I'd just like to say to Carolyn what a fantastic event this is. Does these events fantastically well. It's always a pleasure to come up to TRI and see the great work that's going on in this fantastic environment. And one of the privileges of living in Australia is that we collaborate and work together, and different people do different things, and we're very privileged to all be part of it. So that's great that I'm able to be here and talk about session 2, which is the coming of age for functional imaging. And I must say, as a clinical tool, it's been a long time coming, and it's a pleasure to be talking about where it's got to and where it's going now. So there's 3 speakers in the session, and I'd like to introduce the first speaker, which is Chris Talby. Chris Talby did a PhD at NYU with electrophysiology. He's worked at the University of Sydney. He's been at ANU, and he's then retrained or trained in addition as a neuropsychologist. And fortunately, he's come to understand that imaging is the important part of all of that. So he's going to talk to us about functional imaging in the epilepsy context.
Brian? Okay, so today I'm going to be talking about some of the work that we've been doing recently using fMRI to understand the possible basis of cognitive impairments in focal epilepsy. An alternative title for my talk might have been using fMRI to go beyond where questions and to start asking why questions. And so what I mean by this is that fMRI can do more than just show which regions of the brain are involved in a given cognitive process or are active at any given time, but we can use it to ask questions about how different areas of the brain work together in the service of things like cognitive functioning. So the starting point for my talk is the long-standing structure-function model that's traditionally dominated thinking about cognitive impairments in epilepsy. Now, this model assumes a causal relationship between the structural integrity of neuronal tissue and the cognitive functions that are supported by that tissue. In this sense, it's simply an application of the lesion model that was first advanced by Broca. Now, there's a number of problems with this structure-function model. So while it's been successful in a number of cases, there's also a number of situations in which it's inadequate. So one of these is that the model cannot explain the range of impairments observed in focal epilepsy. So this can be characterized as kind of a lack of respect for lesion location. So for instance, in TLE, temporal lobe epilepsy, deficits are commonly observed in domains such as executive functioning, processing speed, working memory. These are functions that are usually thought of as being supported by regions outside of the temporal lobe. And another problem is the frequency of impairments observed in so-called MRI-negative cases of focal epilepsy. So these are cases in which recurrent focal seizures occur, but for which no lesion or abnormality can be identified on structural MRI. The recent data from our lab, shown here, indicates that cognitive impairments are just as pronounced in these MRI-negative cases as they are in cases with MR-resolvable lesions. So what I'm showing on this slide is 5 examples of memory tasks. The dark blue boxes show, just see if I can get this working. So the dark blue boxes show the MR-negative cases and the grey boxes show healthy controls. So in all these memory domains, if there are impairments in the MR-negative cases, and relative to other types of temporal lobe epilepsy, the impairments are comparable in magnitude. So despite the absence of a structural abnormality in these cases, impairments are pronounced. So the structure-function model can't explain everything then. So we need some other mechanism for explaining impairments in focal epilepsy. Another possibility is that cognitive deficits reflect some type of functional brain abnormality. So in other words, even in the absence of a structural abnormality, could a functional deficit in the brain, such as some kind of abnormal neuronal interaction pattern, explain these deficits in cognitive function? And fMRI now offers us a tool with which we can address these types of questions. The studies in healthy controls indicate that dynamic, task-dependent reweighting of connections in the brain are important for supporting cognition. Now, this is shown here in a slide that I've reproduced from Park and Friston. And the figure shows structural connections in the brain, colour-coded according to their functional connectivity. So this is showing the connectivity patterns at rest, the connectivity patterns during an attentional state, attentionally demanding task, and during a memory task. So the point to take away here is that as we switch between these different tasks, the connectivity patterns changes in the service of task demands. So findings such as these suggest that dynamic reweighting of connections is essential for cognition. So this leads us to the first hypothesis that I want to address today, and that's namely that cognitive impairment in epilepsy can result from a compromised ability to adjust network interactions in the service of task demands. And we address this hypothesis by studying letter-based verbal fluency in 30 unilateral TLE cases and 16 healthy controls. So lesion and imaging studies strongly implicate the frontal lobes in verbal fluency. So this is a task that's heavily dependent on regions outside of the temporal lobe from which seizures are arising in these patients. Now we collected behavioural data outside of the scanner using a letter-based verbal fluency task, so coming up with words, as many words as you can think of beginning with a particular letter. And then we also used an in-scanner block design version of this task, shown here. So we alternated between 30-second periods of just pure visual fixation and 30-second periods of verbal fluency. Now to analyse this data, to look at what's happening with network interactions here, we use what's called psychophysiological interaction analyses, or PPI analyses. Now these analyses measure state-dependent changes in network connectivity. So PPI analyses essentially look at whether the slope or the gain of the relationship between activities in a seed region, shown on the x-axis, and another region of the brain, shown in the y-axis, whether this slope of this relationship changes as a function of task state. So I've caricatured this here with field symbols show activity in one state, called daydreaming, and the open symbols show this connectivity in a state, hopefully listening to the talk, you're not daydreaming, it's a different state. Now the PPI parameter, it captures the change in the slope of this relationship. And therefore it enables us to answer questions of the form, does connectivity between regions vary as a function of psychological state? And if it does, this is assumed to reflect a change in information exchange between these regions of the brain as a function of the task. So we use PPI parameter estimates here to investigate what happens in connectivity between the fluency state and the fixation state. Now PPI analyses, they require specification of a seed region. So we use 2 midline maxima of activation and 2 midline maxima of deactivation as our seed regions. And we targeted these areas because these midline regions have been shown to be important for setting overall brain network configuration during task execution. So what do we find? Firstly, behaviourally, we can see that verbal fluency is impaired in the TLE cases relative to the controls. Roughly 28 words in the TLE cases were produced during the behavioural task versus 48 in the controls. Then when we compared the PPI estimates between TLE patients and controls, we observed a significant difference for one of our seeds, that in the SMA. And as can be seen in this figure, for the SMA controls, showed increased PPI estimates, so increased connectivity between the seed region and the left middle frontal gyrus, whereas on average, the TLE patients showed no net change in interaction during task execution. And so, as I noted earlier, letter fluency is heavily dependent on executive processes like set shifting, strategy generation, self-monitoring. So viewed in this light, the absence of PPIs from the SMA to left frontal gyrus in the TLE patients could reflect reduced top-down engagement of strategic processing during the TLE group, leading to their impairments on the task. In the second set of analyses, we correlated the out-of-scanner performance on the fluency task with the PPI estimates from the seed region identified before. And so we observed significant correlations between PPI estimates and behavioural performance for 2 of our seeds. So for the left posterior cingulate seed, we saw increased connectivity was associated with better performance, increased connectivity to the midline frontal region. This is somewhat unexpected because these regions here, it's coupling between what are normally thought of as 2 antagonistic networks, like the default mode network and the task positive network. However, other groups have previously noted as well that better cooperation between the default mode and task positive systems is associated with better cognitive performance. And this is thought to relate for a role of the posterior cingulate region in tuning network interactions throughout the brain. Then we also observed higher fluency scores associated with a range of areas across the brain when seeded from the SMA region. Now these regions highlighted with the correlation between the PPI estimate and verbal fluency occur in areas that tend to fall outside of the areas where there's strong activation during the task. And so hence activity in these regions were not strongly modulated by the task, and this pattern can be interpreted as indicating an important role for the SMA in setting overall brain state in the service of task domains, including in disengaging task-relevant regions in service of the task. So the PPI analyses I've discussed to now indicate poorer cognitive performance is associated with a less malleable network organisation in focal epilepsy cases. So PPI analyses examine connectivity across the full epoch of a given brain state. So in the task I've shown, we're looking at the full pattern of activity during fixation blocks relative to the full pattern of activity for cognitive blocks. Another question we can ask is what happens at the transition points between cognitive states? So a number of observations suggest that these transitions might be slow in focal epilepsy patients relative to controls. So firstly, processing speed is frequently impaired in epilepsy, with performances falling approximately a standard deviation below normative expectations. So this is shown in the figure here on the right, using the coding subtest from the Wechsler scales from patients in the comprehensive epilepsy program at Austin Health. And it's also been observed that confrontation naming, the responses of focal epilepsy patients can be up to a second slower than those observed in healthy control. So given these observations, this leads to our second hypothesis that that the engagement of a given cognitive network will be slower in focal epilepsy patients relative to controls. So to address this hypothesis, we use the same verbal fluency data that I used to do the PPI analyses in the previous slides. And we extracted time series from 3 different regions of interest. So 2 in cognitive networks, from the task positive system and the default mode system, and then a third ROI looking just in sensory cortex, the ROI and occipital cortex. And in order to facilitate visualization of the responses at the transition points, we calculated folded average block responses here. So we took each block and averaged them together to yield an average transition response. So this slide shows the grid average block responses in controls, shown in blue in each panel, in TLE patients, shown in red, and then the black curve shows the difference curve between these patient and control responses, and the dashed line defines the 95% bootstrap confidence interval. And so this is, again, the task positive network on the left, the default mode in the center, and the sensory ROI on the right. So if we zoom in on the transition points, we can see that it looks like in the task positive system, it looks like there's a slower response in the focal epilepsy cases. There's perhaps a slower response also in the default mode system, but it looks like the basic sensory response to the visual stimuli is matched in time between patients and controls. So we quantified these latency differences by modeling the data using an inverse legit function. And this function basically enables flexible modeling of the hemodynamic response shape. And we can then use this to infer latency from the model fit. And so, as you can see here, these are the model fits I'm showing against the core data point. The fits were very good, with R-squareds generally in excess of 0.9. So, shown here are the underlying hemodynamic response shapes that were fit to the data. And from these, we estimated latency as the point at which the ascending phase of the response exceeded 12.5% of the max response. So it's shown by the diamonds on each plot. So we can see it from these fitted responses that it looks like in the task positive system there's a slower response in the TLE group relative to controls, but there's no latency difference in the default mode or the occipital ROI. And we quantified this by performing permutation-based analyses like permuting the case labels and generating histograms of the null distribution of the latency differences. So these are shown as histograms here. Negative numbers correspond to slower responses in the TLE group, and the asterisk indicates the actual observed response in the true data, the true latency difference. And so we can see here that, as suggested on the preceding slide, that there's a significantly slower response in the task positive system in focal epilepsy patients, but no difference in the default mode or the sensory ROI. Now one might ask, that data was collected with a 3-second TR. This is quite slow relative to what we're trying to do here, so can we do better with higher temporal resolution data? So we therefore looked at a second data set, more recently collected, 15 TLE patients and 17 controls, using a higher temporal resolution sequence with a TR of 761 milliseconds. And we did this using an autobiographical memory task, again a block design task. And in this task, we alternated between visually presented semantic questions, like what color is a carrot, versus autobiographical probe questions. So can you, I want you to recall your, the journey that brought you to the research facility this morning. So I'm going to jump straight into the zoomed-in transition responses for this data. So you can see the higher density of data points reflecting the shorter TR. And again, I'm showing you two cognitive networks, one in the anterior temporal region on the left, and one in the occipital reading system in the center, and then also a basic sensory ROI in the occipital cortex on the right. So these raw data suggest slower responses again in the TLE patients in these cognitive systems, but approximately matched to the response latency in the basic sensory area. Permutation-based analyses confirm this, showing the longer latency responses in the cognitive system, but no significant difference at the arrival of information from the sensory periphery in the occipital cortex. Now this slide summarises the pattern of latency differences across a range of cognitive and sensory networks examined across both data sets. Now in this plot, the occipital regions are shown in the hot colours at the bottom, and the cognitive networks are shown in the cooler colours up above. And data points that fall to the left of the vertical black line indicate slower responses in the focal epilepsy patients. So you can see there's a clear pattern of slower responses in cognitive networks in the TLE patients, and the different panels just show latency estimated at different points on the curve. So 12.5% of max response, 25% of max response, and 50% of max response, just to show that these results aren't contingent upon the latency estimate that is used. So in conclusion, our data show that focal epilepsy patients appear to be slower to engage cognitive networks or to switch between task-driven cognitive networks during task execution. And this appears to be a cognitive network-specific phenomenon. So we don't see this in the sensory ROI. So information is arriving at the brain at the same time. It's just taking longer to initiate a switch. So taken together, the data that I've shown today suggests that a potential mechanism of cognitive impairment in epilepsy could be a reduced capacity to modulate network behaviour in a task-dependent manner. And so in this way, our findings point a path beyond the simple structure-function model of impairment in epilepsy and start moving towards a network account of cognitive impairment in this disorder. And it's important to note here that these types of network effects can manifest in regions remote from the focus of the epilepsy itself. So this has got us around this lack of respect for epilepsy focus that I pointed out at the start of the lecture. Oh, seminar. So why is network behaviour compromised in focal epilepsy? Previous clinicians work from our group, which may be discussed in the next talk, I'm not sure, indicates that increased network segregation is a prominent feature in focal epilepsy. And so one interpretation of this increased segregation is that it represents a homeostatic attempt by the brain to contain the abnormal activity patterns that are emerging from the epileptogenic region, thereby constraining the spread of this activity out through the brain. Now, the cost of such constraining of activity or firewalling of activity may actually be detrimental effects on cognition. So in attempting to constrain the spread of epileptic activity, we're also limiting the ability of the brain to modulate networks in a task-dependent manner in support of cognition. And what about the slowing in network switching? So it's often supposed that anti-epileptic drug side effects are important here. And so while this is almost certainly true, it cannot be the whole account because there's good evidence that reductions in processing speed and reaction time are present even in drug-naive epilepsy patients. So this suggests that there's something intrinsic about the epilepsy process itself that's interfering with distributed functions like processing speed. So this raises the possibility that if we were, sorry, I'm getting ahead of myself. If you look at the literature carefully, you can see that there are reports out there of after successful surgeries and removal of the epileptogenic focus, that there's improvements in things like processing speed in patients. So this gives us the possibility to run longitudinal studies looking at how does resection of epileptic tissue influence brain network behaviour and processing speed. So these are the kind of things that we're looking to explore in future work. So I'd like to end there, acknowledging contributions from some of the other individuals in the lab, and I think there's time for a question or two if anyone has one.
Are there any questions? Chris, one way it sounds.
I'll multitask here for a moment and then introduce myself. I think, there we go. So thank you very much. So I think my role, so I'm a neurologist. I'm a researcher in imaging and have been for a long time. Met Carolyn a long time ago as the clinician who was interested in imaging, and we've had a common journey for a long time doing similar things in different places. So yeah, that's why I said it was so great to be here. I'm at the Florey now as a Deputy Director and a Professorial Fellow at University of Melbourne and at the Austin for the clinical program. And I'm going to take you through epilepsy and a little bit of a journey of fMRI. I don't go as far back as the moon landing, and I don't go as far back as CT, but I go a long way back, and I at least was there at the dawn of fMRI, and I want to show you where we've gone in epilepsy. I want to show you where we've got to in translation to a standard model of clinical care, and then finally introduce the Australian Epilepsy Project, which is our RFF Future Fund Phase 1 study, which I think we're keen to have national collaborations with. Now, fMRI for me started, and for many people started with the cover of this science magazine and this crazy character called Jack Beliveau, who we all miss very much. He did this as a gadolinium injection and found that as you were looking at a visual checkerboard, you could see the visual cortex activating. Now, that doesn't sound that exciting, but at the time this was revolutionary. This was suddenly we could see the brain thinking. We could see function with MRI. Who would have ever believed that? And he came and gave a lecture at London where I was working at the time, and it shows you how these things work. There was a guy in the lab, Frank Brown, who had done some work on susceptibility weighting. Everyone got excited and said we can surely do this without gadolinium. Went down to the scanner, worked all night, got a set of data, and it didn't work, except it did work. We just had to work out how to analyse it. And it took a long time to analyse it, but these are the raw image pictures, left hand, right hand. We describe this omega shape in this lateral sulcus, and then visual activation, so it looked beautiful. But I even remember doing these slides. We actually did 3 transparency slides, and we held them together and took a photograph to get the overlays. So this was a long time ago. And then very, very quickly realised we could look at seizures. As a little boy who was having a lot of seizures, so I was thin enough to lie in the scanner with him at the time. And we showed that when he had a focal seizure, we could see the onset of the susceptibility weighted bulb changes at the epileptic focus. And then even more, we can start looking at this property of neuronal plasticity. You can sort of see transfer of function. So both the left hand and the right hand are using fairly similar parts of the cortex. Suddenly, there was an opening to understand all sorts of brain reorganisations and abnormal behaviours. Importantly, we also were able to look over time period, because there's a temporal domain in functional imaging which we're only beginning to exploit fully. And this is a time course. Here's where someone was lying in the scanner who were having frequent seizures. This was, monitoring the scanner. They lay there all day if they had to, until they had a seizure, and then they were allowed out. And you can sort of see that left hemisphere, right hemisphere, there is this change in bulb intensity function starting 20 more minutes before the seizure onset. And the most interesting thing is, in this case, the seizure onset came from here, and this was what was happening. This is what was happening in the other hemisphere for a long time before seizure onset. And this is where we got the first clue that the brain doesn't sit there passively and allow seizures to happen. It happens to be a homeostatic organ, and the brain is actually interested in it not having seizures, and it tries to do it. So these were big insights. So what's next? What do we want to do? We want to do a lot of things with all of this advanced imaging. We want to predict outcome, seizure recurrence, which medication you can be on, what happens to cognition, you've seen in Chris's talk, side effects, what to do where do they start, what networks, should you have surgery? And so essentially we need clinical decision support tools, and you've heard a lot of that in the introduction today, and we, like others, are following that journey and being part of it. So the nature of the data we've got now is pretty remarkable. So we've got all of this data. Bad build. So we've got structural data, which we're doing a lot with. We've got the tractogram, if you use a good model for white matter pathways. So we've got this information of how the tracks go, and we've got this dynamic nature of brain function that we can exploit in all sorts of tools. And as I'll show you a bit later, in clinical, we pretty much only exploit that bit. So where should we be going? Just want to touch base on diffusion because I'm not sure if everyone knows this story, but we've got to move beyond DTI. We've published a bit on this. If you have DTI, you're only allowed one direction in each voxel, and these voxels are big, 2 millimeters at least. Isotropic, so you get big blobby things, and you have to work out the tractogram, how to go through that. You really need a model that can deal with crossing fibres, because 90% of your voxels have crossing fibres, and it has consequences. How could you find a network that ended up here when you have data like this? You need data that actually includes the tracts when they go through these crossing fibres. So you need a better model than DTI. It's just, and this is the section, so that's the reality, and this is not the reality. And the second thing about diffusion is this property of super resolution, which I'll talk about again. If you have a single voxel and you have these streamlines that are worked out by connecting lots of voxels together, you're bringing into that voxel information that is informed from voxels outside it. So that pathway runs through the top corner, that runs through the bottom corner, so you have spatial information within the voxel. And if you do it in multiple directions, you've got lots of spatial information. So what you can do effectively is throw the original voxel away and use this spatial information as your model, and then the model can be made whatever resolution you like, and you can end up with high resolution. This is a diffusion image that I should show you the original. It's 2.3 millimeter isotropic voxels in diffusion, and using this process, you've got 100 millimeter resolution with pathways that are realistic. So this is truly super resolution by using this quality of diffusion, and that's one of its most powerful bits. And you know, for those of you who do animal research, here is one of these diffusion tractography. You can see the fibres going into barrel cortex in an image acquired at 2 cubic millimeters in a rodent. So it's quite extraordinary that this does work, and you can actually see the barrel cortex. So it does show realistic information, and that's all available in software here if anyone's interested. Now, we want to combine that with function to reveal networks, and that brings us to the tract-weighted imaging framework. And what you can do, this is just a simple resting state network that is extracted from functional data. This is the tractogram of high quality, and if you combine the two by propagating intensities from this through networks that are connected through the voxels that have some intensity here, you end up with an image like this that shows you both the bits of grey matter that are functionally activated, plus fibre tracts that may be important for that function. So everyone knows with the spinal cord injury, if you cut the spinal cord, it doesn't matter that your motor cortex is working, your foot still doesn't move, right? Very clear example. So if you have a bit of grey matter function and you cut the white matter tract, that function is not going to work. So what we want to know is not this is just the grey matter, and it's not just this. It's what is the bits that are critical to that function, and that is this, which is tract-weighted imaging. Now, how do we use that? Let me just show you one example. Here's a boy, 14-year-old, has this lesion in the insula underlying all of his speech network. It's a fairly large lesion. To take this out would normally leave a large resection of Broca's area of the inferofrontal cortex, very hard to get to. He was actually counselled before surgery that he had a 50% chance of never speaking again, which he was happy to take. This is after the operation. This is the surgical intervention. So how did it? You can sort of see that the tumour is gone. There's a small hole left. How did that happen? It was done this way. This is by using track-weighted functional imaging. This has got the directional information still in it. Here's the lesion. You can see the fibre tracts, but this is track-weighted. These fibre tracts are only visible if they're propagated from parts of grey matter that activate the brain. And what was done with great care is this. You can see over here there was a part of the cortex that didn't seem to be involved in the networks, and that's pretty brave because that's in a part that is right in the middle of Broca's area. So the surgeons did a resection through this part that didn't seem to be involved in either functional networks or fibres. They found a pathway through 3D navigation to get to the tumour and went in through there and resected it with no deficit to language system. So this is the whole point. You need to know the bits that you can't either cut the cord or cut the cortex. And that's the image that led to the idea that this bit of cortex probably wasn't participating and could be sacrificed. Now, is that the perfect proof? I don't know, but at least that's the future. And then we can put this together when we have EEG fMRI. We get a blob. That's a grey matter blob, but the symptoms are all in networks. So this is a propagated network from the EEG fMRI abnormality. And what we're proposing is it's more likely that the seizures would quickly spread to there or to one of these other places where there are fibres propagating from the abnormality. So we're starting to think of networks of function and structure, both normal and abnormal. So then I want to turn to the other concept of super resolution, the temporal super resolution. Because one of the frustrating things about EEG fMRI, we say we combine EEG information with MRI and we get the spatial resolution of one, the temporal of the other. But we don't really. We've only ever used EEG to say an event happened now, put your hand up. That's using one moment in the EEG. I'm not going to go through this, but there is a way of super resolving the temporal resolution as well, and that is within the standard set of bold data that we've collected, which has 4 dimensions, 3 of space and 1 of time, at a TR of 3 seconds. You can put a different model for each electrical voltage on the assumption that that electrical voltage is being generated by a part of the brain, and therefore that distribution will model better, and therefore we can see which part of the brain is active. And that's using this, finding a maximum discrimination in n-dimensional space that's only shown in 2 dimensions between resting state EEG and abnormal EEG, and then we're measuring from the mean line how far the electrical activity differs from this mean line, and then using that in our bold model. So does it work? Well, it does. Here is a patient who all the clinical information suggested that the seizures might be coming from up here. You can see with our track weighted, that's the actual blob. There's a pathway that goes up there, and you can see here how the functional imaging works. So, oops. You can see that the activity comes on and then it spreads to that frontal lobe. This is 1 second of data. It's an averaged, it's 40 events with a spike and wave. And what we're doing is looking at 50 milliseconds and creating a different model at each 50 milliseconds. And it shows us realistic networks. And it's done that in many epilepsy patients where you have this data. So here we have, through having 40 events averaged and looking at the variance of each one and creating a model, we've got a way of getting temporal super resolution at the physiological scale. Now finally, there's an area of connectomics I just want to touch on for those. I know this is a more general audience than just neuroscience, so let's just introduce it. I love this image because it sort of reminds me of how I've wasted a lot of my time, and it's maybe not going to... Sorry about the sound, don't know how to turn it off. But you see here, we've all been on these edges. These are nodes, and this is a network. It's an operating network during the day of what happens in the world. Can you turn that sound off? Well, that's great. So here we have airports, which are natural nodes, and these are edges. And the mathematics that keeps this whole thing running is connectomics, because a plane's laid, how does it fit into this network? It's pretty complex. So is the brain. And in the brain we have networks, and we have local neighbourhoods. You can see this local neighbourhood in the temporal lobe. We have bridge club nodes, which are people who are connected to everything and influence everything. Carolyn Mountford's the type people in the network imaging, and these are the sites. And using this idea of airports or nodes in the brain and edges that connect them, you can create a whole range of parameters that we can then explore. And you know, one of the ways of looking at this connectivity is this very interesting paper we recently published, where we've been trying to look at the switching rate. If you've heard from Chris's talk why we might be wanting to look at how flexible the brain is, how fast it switches, well, you can sort of see that if you have a little network, this belongs to this network functioning at this time point. We look at the next time point, this no longer belongs to that network, it's belonged to this network, so we can say that's switched. And then this little node that's in this network at the next time point now belongs to that network, so it's switched. So this is the switching rate, the parameter. And one of the things you see here is, quite remarkably, the switching rate predicts remarkably well how many hours of sleep you had last night. It also predicts very well how well you'll perform on an NBAC task. So this is from the Human Connectome Project, which is large data. So quite remarkably, it's very sensitive in normal brains to this phenomenon. Exactly when you get up on the wrong side of the bed, you have a different switching rate, you perform less well, and it's been known since a long time ago. So we now have a very sensitive measure of brain performance in normals, and we're yet to explore it in epilepsy. However, what we have explored is other measures of connectivity. I'll just tell you this brief story that I'm very fond of. Here is a property called local connectivity, which I'm not going to go into. In this brain of this girl, she had a remarkably focal area of local connectivity that was well beyond the normal of controls. And you can see it was tiny. It's very close into her language area. She's language dominant. The MRI scan, the best radiologist couldn't be convinced that there was anything there. Simon Harvey was convinced, but we couldn't see it. And the remarkable thing is, in surgery, and anyone who's a surgeon here, to just take this exact tiny bit out was sort of almost a heroic task and a research project in itself. And we published this as how small can the epileptogenic region be. So before surgery, after surgery, obviously no deficit, and she's seizure-free for 6 or 7 years now. But you can see this lesion, how small it is. Yet the effect on the brain is remarkable. Here is a parameter that we're talking about that comes from connectomics. It's a property called small worldedness, how small world is the brain working at that time. Normal controls are in this grey zone, and this is her before surgery. And she's clearly in a different zone. She was one of those people who, when you spoke to her, you were about to start your next question, and then she'd start responding to the last question, this latency thing Chris is talking about. And when she came out of the theatre with that very tiny operation, everyone noticed she was different. She was responding immediately. So as she came out of the anaesthetic, still on the same medications, and 3 weeks later, her small worldedness has moved this massive amount. And you can see normal brains are all out there. Everyone noticed the personality change. And so very, very tiny parts of the brain can clearly cause very large scale and network effects. And this is seen in a bigger population, focal epilepsy. You can see that the epilepsy networks are different from the normal population in all focal epilepsy, so on a large scale. This is a common phenomenon, likely to be related to the epilepsy. So now translation. I think we all saw X-rays quickly, we saw CT scans quickly go into clinical practice, we've seen MRIs of brain structure come into clinical practice and then get better and better and quicker and easier to interpret and use. Yet we've done a whole lot of stuff since the early 90s. And how much of it is available in routine clinical care? Almost none of it. I mean, unless you're in a research dedicated spot or you have a champion, there's nothing in routine care. There's a massive translation gap. And we feel we as leaders in this area have to do something about that. So that led to us to propose the Australian Epilepsy Project, which is now having some traction in terms of bidding for this very large translational project nationally. And the aim of this is to change lives of people with epilepsy, because at the moment, unless you get to a centre like ours, you don't get all this technology. We want to make sure that every Australian has access to that technology and that expertise and that ability to interpret it. That's an immediate gain for everyone in Australia. If we can set up this in research, that will make a massive difference. But part of our motivation of doing it is to supercharge medtech. The thing about AI is it's wonderful, but it needs large-scale curated data sets. And the way we're going to generate these highly curated, large data sets in this advanced imaging is by providing that initial service with human intelligence and translate that to clinical care with artificial intelligence. And we're looking for 10 to 15,000, what we're calling epileptomes. And that means we're going to have advanced imaging data of the sort I've just been talking about. We'll have genetics data, we'll have cognitive data, and we'll have good clinical histories, highly curated across all the Australian epilepsy networks, with sites in every state, lifting the standard of healthcare. So we believe it's time to change all the lives of people with epilepsy, not just those that we do research on. And we're doing it by access to technology and expertise in the first stage. And then we're going to supercharge medtech with big data and AI. And it's like the HCP project. The most important part of the gold is really generating that epilepsy data, epilepsy-specific data. Once we have that that's properly curated, people all around the world can do it, and we feel a responsibility to do it. And it's important to do it in Australia, where we have unique connections like generated through meetings such as this. And this is a little model of what we're planning. There's the other thing that, healthcare is just unaffordable if everyone gets this right. So something has to change about the cost structure. The standard of care outside our expert centres is bad. We think we can lift it with this project pretty quickly so that everyone's getting the current best practice. Then using advanced machine learning techniques as we get larger cohorts, we can improve the future standard of care, and the aim is to do it at a lower cost. And we have to change the healthcare model if we're going to have this future of better care, because the standard way of doing it is too expensive. So all of this, we put together a meeting. This is our recent meeting. This is our epilepsy research retreat, where we deal with genetics, cognition and imaging, and a lot of people that influence the thinking. So thank you very much. Now, anyone have any burning questions, or is sleeping continuing? Hi, Carol.
Sorry, be boring. Have you tried to correlate the rate of connectivity with someone's capacity to deliver on task? And I guess the brash way to put this, is it related to intelligence?
I think Chris can just about answer that better than I can. We haven't done this at large scale. We've done one of the frustrating things, I guess, when you're in research, you're small N researchers, because that's all we can afford. That's one of the great things we're trying to do with the Australian Epilepsy Project. You can imagine in 5 years, if we have 15,000 data sets, we've got a fully cognition data set, genetic in the clinical context, we can get the correct cohort, just run the experiment on that data, answer that question very easily, and not in a small N way that's unreproducible.
So is this something that we should do at multiple centres?
Yeah, so the plan is that we'll have centres, wherever centres want to be, where they've got the capacity to deliver. So at the moment we're trying to work out what that is. It'll have to be advanced imaging. In this ramp years between clinical care and clinical care, where we take over the program as a research program, my preference is to do it at research sites where we've got research people who can, and we'll pay for research time on scanners to collect our data. And we'll have centres where, we're thinking of doing it as more of a trials model that will pay for a completed data set. And we'll work with any centre and we'll transfer any skills anyone wants out of our centre to that local centre, or we'll manage that problem centrally, whichever people want. So each centre can be different, but we need multiple centres around Australia. In Queensland, we've got ambitions to have at least one centre in Brisbane, Townsville, maybe in Cairns, depending on, we're dependent on having epileptologists that have some sort of interest at the front end. So we very much want people to be involved. We think this is an incredible opportunity because the gold in the future is going to be the data. A lot of AI techniques, but the better the curated data, the better the answers. And we're responsible for epilepsy. And I've seen people try to do this in Europe, they've tried to do it in America. The silos are too big, the connectivity between centres isn't enough. We can do this in Australia.
Hi, thank you for that talk. Share some examples of international siege activity. Have you applied your network switching rate models to left right switching in the brain?
It hasn't been applied to anything in epilepsy yet. That's just been published in PNAS. That's one of my postdocs. We've been pushing for, it's the classic quick answer after about 10 years of work. We've been looking at the switching rate problem for a long time, thinking it must be critical and trying to develop techniques. So the reason that popped out is we had the 10,000 human connectome project to do it. Now we need a 10,000 epileptome data to actually take it further.
I have a simple, I'm sure it's a silly question, but the issue of what's going on in terms of the switching rate and the cognitive change, is the reason that the circuits are being isolated is because there's just too much data on those circuits and that would interfere with everything else? Or is it that there's the disturbance in the epilepsy is more than just the focal lesion?
Yeah, the disturbance is definitely more than the focal lesion. It's all the secondary consequences of the brain, both trying to control it and the consequences of having a storm through the brain occasionally that disrupts everything. One of the things that's popped out for us is, I didn't really understand this as a neurologist, but there is a dedicated system in the right side of the brain called the von Economo neuronal system that roughly parallels the specialisation of the language system in the left hemisphere. I guess we all thought the right hemisphere was sitting there as just sludge, but it turns out it's probably not. And what that von Economo neurons do, there's long spindle neurons that only came up in primates. They've got very long axons and they've got very strongly inhibitory. And what they probably do is inhibit function so you can move on to the next function. And we found that they're especially involved in both concussion and in epilepsy, focal epilepsy. So working hypothesis at the moment is for some reason that inhibitory system is overwhelmed by the existence of epilepsy. So, that's a bit more than you were asking, but it's remarkable that I'd never heard of this network. I'm a neurologist, I'd never heard of this function of the right hemisphere.
There's been no mention of using NIRS.
Using what?
NIRS.
NIF? Yeah.
So do you use NIRS?
Oh, okay. I haven't used it since I was in Great Ormond Street. We were using it in kids because the bones are a bit more amenable to access, and it's a good technology. I really don't know anything about how good it's become in humans. If you wanted to comment, I'd be interested. No, those sort of technologies, it's a bit like, I got so passionate about MRI, I took my eye off CT and then I turn around every now and again thinking CT will be dead and out the door, and then it keeps getting better. So, you've got to watch other technologies, I agree. Anyway, we must I think we better move on then. So, really pleased to have Marcus Gray, who's from TRI. He's local, he's a psychologist, he's interested in neuroscience. And like me, he did some training at the Wellcome Trust in London, and very pleased to hear him talk about brain imaging in patients with gastrointestinal disorders, the organ with the next most neurons.
thank you for the invitation to talk at what's so far turned out to be a fantastic seminar, and also it's an honour to speak in this section, which has been it contains some great science in my opinion. I'm sure you'll agree. So, as Graham mentioned, I'm going to talk about how brain imaging can add to our understanding of gastrointestinal disorders, and I'll speak a little bit at the end about its translational potential, along with other measures in delivering personalised treatment approaches. Now, this might seem a little bit strange to some of you. Epilepsy is obviously a brain disorder, but what can functional imaging add to our understanding of gastrointestinal disorders, you might be wondering. Well, as we've heard, neuroimaging offers a number of approaches to investigating the brain's role in gastrointestinal disorders. So we've got structural imaging, which tells us about localised brain volume. We've got diffusion imaging, which tells us about white matter connectivity, and also potentially about demyelination in white matter. We've got MR spectroscopy, which can tell us about neural metabolism or brain metabolism. And we've also got functional or T2 style or bulb-layered imaging. And that tells us typically about functionally correlated networks, either at rest or during experimental tasks, or it can tell us about the responses of specific neural circuits during carefully designed experimental challenges. Each of these have been pursued with GI patients, each of these modalities, although the majority has been structural or functional imaging. There's a fewer number of diffusion-weighted imaging studies in these patients, and there's really only one or two decent spectroscopy imaging studies. But we here are investigating across all four of these groups, with Professor Mountford giving some assistance with the spectroscopy in particular. But because I've got fairly limited time today, I'm just going to focus on some functional imaging studies that we've recently come across. So gastrointestinal disorders, for those who aren't terribly familiar, are extremely common in the general population, and they're also associated with a substantial burden of disease. And they basically divide into two broad categories. You have inflammatory bowel diseases, such as Crohn's disease and ulcerative colitis, and you have the functional gastrointestinal disorders, such as functional dyspepsia and irritable bowel syndrome, which is principally characterised by recurrent abdominal pain and altered bowel motility. But IBS, irritable bowel syndrome, is unusual. Unlike IBD, in IBS there's no obvious cause for the pain and the altered motility. So, although pain can persist in irritable bowel disease, inflammatory bowel disease, after GI lesions heal, that is unusual also. And in those patients, after the lesions have healed, if pain and motility problems persist, they look very much like IBS patients. So IBS is an enigma that we're trying to uncover. And research has been very useful so far. We've demonstrated, or others in the field have demonstrated, clear biological abnormalities across a range of levels. So starting from abnormalities in the gut epithelium, to immune responses, to changes in neuroendocrine function, differences in stressor responses, and microbial dysbiosis. Symptoms can also be exacerbated and commonly are by psychosocial stress. So as Graham mentioned, I began research into autonomic neuroscience and psychiatry in London in 2005, although I've only began studying GI disorders more recently. And a fascinating feature of GI disorders is there's a clear elevation in psychiatric comorbidity. About 20% of outpatients with irritable bowel disease report depression and anxiety, and that's significantly more than outpatient controls who don't have IBD. So there's a massive increase in both depression and anxiety in IBD patients. Similarly, up to about 50% of patients who see their GP for treatment for irritable bowel syndrome also have comorbid anxiety or depression. So this strongly implicates gut-brain axis in GI disorders. And we know that there are many bidirectional influences between the brain and the gut. So just to name a few, in general you have autonomic regulation of the enteric nervous system, which controls gut gastrointestinal function. You've also got afferent feedback from the enteric nervous system back up to the brain. You've got regulation of mucosal secretion and motor function. And you've also got neuroendocrine regulation. Then, of course, you've got the immune function. So there are very good reasons to suspect a link between the immune system and psychiatric symptoms. Inflammation exerts powerful influences on behaviour by changing motivational drives. In particular, inflammation induces alarm and avoidance, behaviours which facilitate withdrawal and wound healing. Traditionally, immunoregulatory bacteria in our guts kept at break on these immune systems, but in our cleaner, more modern world, these old friend bacteria are less common, leaving us with a mechanism which links inflammation to anxiety and depression. Typically, in this field of research, we call these sickness behaviours, but they're behaviourally and psychologically very close to anxiety and depression symptoms. In 2009, our group in London were one of the first in the world to demonstrate a neural basis for inflammation-induced sickness behaviour. This is a functional imaging experiment. It's a double-blind, randomised, controlled crossover design. And we had 16 healthy males who were scanned twice, while viewing pictures of emotional facial expressions. Before each scanning session, on 2 separate days, they received an injection, which was either a placebo or a typhoid vaccination, and each got both in randomised order. Typhoid vaccination induced a systemic immune response, so it significantly increased interleukin-6, although not interleukin-1RA. And increased inflammatory response was associated with increased feelings of confusion and fatigue at 3 hours after injection. By correlating these subjective changes with neural activity, we were able to identify changes in the mesolimbic dopamine system, the subgenial cingulate, the medial prefrontal cortex, and the temporal sulcus. The subgenial cingulate appears particularly important here. Let me just say yes. We also examined how functional activity within this region, the subgenial cingulate, was communicating with all the other regions of the brain by doing a PPI analysis that Chris mentioned briefly before. And we found that increasing inflammation changed the way this region of the cingulate communicated with the medial prefrontal cortex, the nucleus accumbens importantly, and the superior temporal cortex. So not only was inflammation inducing mood, which was substantiated by underlying neural activity changes, but the way that these modified functional regions communicated with the rest of the brain was also influenced. So, as I said, this talk is about GI disorders, so I decided more recently, when I began investigating the role of inflammation, to translate these sort of approaches into gastrointestinal patients. Rather than inducing inflammation, as we did in the previous experiment, I've decided to look at the impact of potent anti-inflammatory therapy, specifically with anti-TNF-alpha. Anti-TNF-alpha is a powerful anti-inflammatory. It effectively promotes lesion healing in the intestines, and it reduces acute GI inflammation. Most patients who are on this treatment will be inflammatory bowel disease patients with clear lesions. And in these patients, anti-TNF-alpha clearly helps heal mucosal lesions. These patients are typically maintained in a stable condition by an injection every 4 to 6 weeks. So it's quite, there's a lot of time between injections. There are also a few reports that anti-TNF-alpha might have antidepressant effects in patients with IBD, and possibly also in patients with other inflammatory conditions such as rheumatoid arthritis. So it's intriguing. Our focus was on the interoceptive circuits. So essentially, interoception means the brain's sensing of the body state or physiology. In the past 2 decades, we've mapped out the interoceptive pathways from the spinal cord up to the cortex. And we've discovered that this system, surprisingly, is quite similar to the somatosensory and nociceptive pathways. Primary visceral afferents enter at the dorsal column of the spinal cord, they project up to the pons, and then to the pons, and then the ventrolateral medial nucleus of the thalamus before projecting out to the nuclear cortex. and the cingulate cortex. The insular cortex, amongst other things, supports viscerosensory cortex. So it instantiates a remapping of visceral afferents. And the anterior cingulate cortex, amongst other functions, helps to regulate visceromotor output. So functional imaging studies in these disorders have often identified the insula, typically during experiments that involve rat-filled balloon distension, like the issue studies here. So if you directly activate viscerosensory afferent signals, you see increased activation within the insula. That's typically been interpreted as evidence of intraception circuits. But it's interesting to note, I think Chris's results also showed some blocks in the insula, and in fact, a lot of brain imaging studies you look at will also report insular activations. And it's important to recognise that these regions are heteromodal, they don't just do one thing, they generally contribute broadly to a range of functions. So the assumption in these studies that these blobs here represent viscerosensory afferents, I think is potentially questioned. So that's why we decided to map this out in a lot more detail, specifically by inducing experimentally intraceptive circuits. This is an example of one of the tasks that we used. It's very simple. You either direct someone's attention either internally on their internal physiology, so try to sense your own heartbeat, or externally, watching a picture on a computer monitor that flashes. You just ask them to silently count to themselves either their own heartbeats in condition or pictures in their condition. And this simple manipulation of attention, they're seeing the exact same stimuli on the screen. The only thing that's different is what they're focusing on. This strongly recruits intraceptive circuits. And as you can see here, very significant, cellular controlled, bilateral insular and anterior cingulate. So we were very pleased with this task. The task really robustly engages intraception. So what's the effect of inflammation in this, or specifically anti-inflammatories? Well, we didn't see any effect of anti-inflammatory therapy on these circuits. Intraceptive circuits didn't change before or after anti-inflammatories, so we're a bit puzzled. However, I then went on to investigate in a bit more detail what these anterior insular regions were doing. And again, this is a PPI analysis, the same type that Chris explored earlier, where what we're doing is we're extracting the function of this region and we're saying, how does that function in that region communicate to all the other regions in the brain? That'll give us correlations with every other region in the brain. But importantly, we then times that by experimental factor. So is that connection changed when someone is focusing on their own heart versus when they're focusing on the external world? And that's the effect that we're looking at. We then went one step further and said, how is that specific intraceptive induction of this communication changed by anti-inflammatory treatment? And what we noticed was there was a clear connection to the amygdala, which was reduced after reducing inflammation. And that's interesting. We know that the intraceptive circuits is representing physiological state, and we think that is translated into effective symptoms like depression and anxiety. Where if you reduce inflammation, you reduce the influence of these systems on the limbic system. So we thought that was pretty interesting. We then went on, I'll be fairly brief, to look at a few other important components of depression. For example, motivational change during anhedonia. So decreased motivation. How do motivation circuits are they implicated? They're typically different in depressive states. People feel less drive, less motivation. Can we see an impact of inflammation and treatment on motivational learning? And secondly, cognition. We know here's Beck's negative triad that says cognitive theories of depression say depression is also a cognitive disease. It is associated with changes in cognition, negative thoughts about the self, about the world, and about the future. And you can see these cognitions by measuring the way people think and talk. So we thought we'd look at that also. So essentially reward learning was tested by a reinforcement learning task. People were shown two strand shapes, they just had to choose one of them at random. Probabilistically, this one helped you win money, this one helped you lose money, and neither of these did anything. So you start off not knowing anything, over time, 80% of the time you choose that, you get rewarded, you learn fairly quickly. But that's a good choice, and that's a bad choice. And you can map how people acquire this knowledge by mapping their behavioural choices over time. We did that with these patients, and we were able to show that anti-TNF alpha increases reward response in the nucleus accumbens, and it also increases loss responses within the insulin. And interestingly, the changes in vector pressure inventory scores, so depressive scores, correlated very nicely with changes within the insulin function. So that implicates these motivational learning processes are also modulated or changed by inflammatory state. Last of all, we looked at cognition, and in particular, implicit cognitive biases, or about the self. So this is a task that I modified from the existing type of task. It's a behavioural task where you simply have to make rapid decisions to classify sets of words. And the words are positive or negative health words, and self or other associated. And by pairing them up, by saying, is this one of these two categories or these two categories, and examining the reaction times, you can see that people are typically faster when they're identifying positive and self words rather than positive or negative words. And likewise, negative and self words are slower than negative and other words. So by looking at the reaction times, people aren't aware of this, but the subtle behavioural changes, you can measure someone's typical health biases. We like to think of ourselves in positive lights as well as being healthy. So we did this in the patients as well. What we see is a complex three-way interaction, but essentially this is the important box. This shows the degree of positive self-bias in dark green before anti-inflammatory treatment, significantly increased, massive effect size after anti-inflammatory treatment. So their responses were much more efficient. They were much quicker at saying, I'm in the positive group, which we think is indicative of good, healthy cognition. We then took those same modelling processes and applied it to the imaging data, and we're able to show that that behavioural effect, the increased positive implicit bias, was explained by exactly the same changes on a trial-to-trial basis in the responses within the amygdala, right prefrontal cortex and posterior cingulate cortex. So again, we've got the amygdala implicated in cognitive affective processing that is changed when someone is in an inflammatory state versus an anti-inflammatory state. So I'll just finish up this talk briefly by summarising what we found in those three studies. We also showed that gastrointestinal symptoms themselves were reduced. We made people drink large quantities of liquid as a challenge and then report how they felt: pain, bloating, sickness, these sorts of things. Anti-inflammatory treatment significantly reduced their negative GI symptoms. It also changed the connectivity between the intraceptive systems and the limbic system. It changed motivation sensitivity to loss and reward, and it appears it changes implicit cognitive biases about one's own state of health, which I think is interesting. From here on, I'll briefly mention two avenues for ongoing research. We've got currently a study into visceral hypersensitivity, which is looking at how what may not be painful sensory stimuli in a healthy person can come to be perceived as painful in someone with IBD or RDS. This clearly happens. We're not sure why. It might be because nociceptive transmission is increasing efficiency, or it could be for cognitive reasons like expectation, hypervigilance, and catastrophizing. If you're expecting a terrible pain, chances are you'll notice it more, it will affect you more. In fact, probably both of these mechanisms are happening. But what might be interesting is they might be differentially affecting inflammatory bowel syndrome, which might be more of a cognitive driven disorder. Inflammatory bowel disease, which might be more of a lesion driven disorder, visual sensory signalling, versus irritable bowel syndrome, which might be more associated with psychological drive. Secondly, the approaches I presented here are examples of carefully designed specific experiments that we put people in the scanner, we ask them to do, and we see changes in a specific circuit. But we know that probably a systems biology approach is the right approach to take to these disorders. They've been adopted widely across other areas of biology, and that sort of suggests that what we know is true. These disorders are functionally diverse. They include a number of interactive components, each of which contributes only a small fraction of their variants and symptoms. And there are probably a number of underlying pathophysiological mechanisms, Some people might have their symptoms which appear similar, largely driven by this mechanism. Other apparently similar symptoms might be driven by quite a different set of mechanisms. And so it's important to take a broad range and consider multiple underlying mechanisms. It's very difficult to get at in the approaches I've presented so far where you have small numbers of patients who go through a specific task. So the approach seems much more suited to the sort of approach Graham was mentioning with your epilepsy vision, that you have large data sets that are assessing across a range of things, so genetics, biology, microbiome, blood-borne measures of inflammation, potentially localized lesions, additionally localized inflammation. And this sort of approach is really well suited to multivariate machine learning approaches. These approaches are fascinating. We've heard again this year about the excitement these approaches are driving, but you need lots and lots of data for them to work properly. And that's why I'm excited to be working in a new project with existing biobank studies where we are looking at genetics, symptom profiles, functional imaging, structural imaging, across patient groups of 10 to 20,000 patients in IBS, similar in IBD, similar in controls. So with these sorts of numbers, we have the potential, I think, to produce something useful. And last of all, I guess the overall aim is to work towards personalised classification and treatment. So if you can differentiate different underlying mechanisms, then you can do better than our current approaches, which is rule out existing disease pathologies and then sequentially move through this type of approach, this type of approach, this type of approach. It really is a checklist, A, B, C, D, E, F, G. You get to the end, if they still don't respond, that's it. With these approaches, we have to be able to offer people the specific combination of therapies that they need. Thank you.